Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 507 of our pharmacotherapy series, which majors in anemias. The next case reads, CPM is a 62-year-old woman diagnosed with stage 4 ovarian cancer. She is being seen for her fourth cycle of chemotherapy with carboplatin and paclitaxel. She reports shortness of breath and fatigue when she walks upstairs, but otherwise has a good performance status. Her CBC indicates the following: a hemoglobin of 9.7 grams per deciliter, a hematocrit of 29%, an MCV of 90 mcm cubed, reticulocytes of 100 × 10⁻³ per microliter. The peripheral smear shows normochromic and normocytic RBCs, and iron studies are within normal limits. So my next question to you reads: what is the most likely cause of CPM's anemia? What is the appropriate treatment? CPM appears to have malignancy-related anemia, which can be characterized as anemia of inflammation or chemotherapy-induced anemia. Anemia is common in cancer, occurring in up to 30% to 90% of patients. The etiology of anemia in cancer patients is frequently complex and a conglomeration of various attributing factors such as comorbidities, malignancy, blood loss, nutritional deficiencies, and treatment with radiation and/or chemotherapy. Chemotherapy-induced anemia is the result of hematopoietic impairment affecting RBC production and nephrotoxic effects of chemotherapy agents, such as platinum-containing agents, decreasing erythropoietin production. It is generally normocytic and normochromic and develops over the course of treatment. As with CPM, the chemotherapy-induced anemia is often classified as mild to moderate, and patients present as asymptomatic or mildly symptomatic, weakness, decreased exercise tolerance. Factors that can influence the incidence of malignancy-related anemia in patients with cancer are the type of malignancy and the stage and duration of disease, the type, schedule, and intensity of treatment, and history of prior myelosuppressive chemotherapy or radiation. Cancer patients receiving chemotherapy should be routinely screened for chemotherapy-induced anemia with a CBC. As per the NCCN Clinical Practice Guidelines in Oncology, NCCN Guidelines, evaluation for chemotherapy-induced anemia should begin at a hemoglobin equal to or less than 11 grams per deciliter. Additional tests including a peripheral blood smear and reticulocyte count as well as other potential causes of anemia should be performed. The recommended treatment for chemotherapy-induced anemia is comprised of transfusion or use of erythropoietin-stimulating agents with or without iron supplementation. Therapy should be directed to the underlying disease, if possible. When considering treatment options, transfusion with packed red blood cells should be used when rapid correction of hemoglobin is warranted with an expected 1 gram per deciliter increase in hemoglobin and 3% increase in hematocrit with a single unit of packed red blood cells. The use of transfusion for chronic management is associated with known risks, notably an increased risk of thromboembolic events in patients with cancer. Conflicting data exist regarding the effect of transfusion on mortality. Erythropoietin-stimulating agents with or without iron supplementation should be considered for long-term management of anemia in a patient with cancer, because it has been shown to reduce transfusion requirements. Large, randomized, multi-center trials have failed to show a clinical benefit to using erythropoietin-stimulating agents in anemia that is not chemotherapy-induced. The reported increased risk of mortality and tumor progression in clinical trials of anemic patients with head and neck, breast, non-small cell lung, lymphoid, and cervical cancers receiving erythropoietin-stimulating agents resulted in a black box warning being added to all erythropoietin-stimulating agent product information to advise about these and other increases in serious adverse events. Erythropoietin-stimulating agents are recommended for anemic patients with cancer who are receiving myelosuppressive chemotherapy and the intent of treatment is not curative, with the possible exception of small cell lung cancer, as there are no clinical trials reporting a deleterious impact on survival. As recommended by the FDA, treatment with an erythropoietin-stimulating agent should not be initiated until the HGB is less than 10 grams per deciliter and there is an additional 2 months of chemotherapy planned. The lowest dose needed to avoid RBC transfusion should be given, and use should be discontinued at the end of chemotherapy treatment. Although response rates to erythropoietin-stimulating agents have been reported upwards of 70% to 80% in clinical trials, not all patients will respond to treatment. The most common cause of non-response to erythropoietic therapy is absolute or functional iron deficiency. Iron studies should be evaluated before and during therapy with supplementation given if needed. Oral or intravenous iron may be used for supplementation, but data from clinical trials show intravenous iron is superior when given with an erythropoietin-stimulating agent. In CPM's case, the clinician may choose from a number of anemia management options. For example, the current course of chemotherapy can be delayed to allow for hematologic recovery and resolution of anemia symptoms. Alternatively, an RBC transfusion can be given to relieve her symptoms and allow her to better tolerate chemotherapy. Erythropoietic therapy with epoetin alpha or darbepoetin alpha also should be considered because the patient has metastatic disease, not curative, and will continue on chemotherapy until disease progression. Treatment with epoetin alpha or darbepoetin alpha increases hemoglobin and decreases the need for blood transfusions. If treatment with epoetin alpha is desired for CPM, therapy can be administered at an initial dose of 150 units per kilogram subcutaneously 3 times a week or 40,000 units once a weekly. Alternative dosing regimens, 80,000 units every 2 weeks or 120,000 units every 3 weeks, have proved to be safe and effective in terms of hematopoietic and transfusion effects. Darbepoetin alpha is also a treatment option for CPM. Initial dosing of darbepoetin alpha is 2.25 micrograms per kilogram subcutaneously once a week or 500 micrograms every 3 weeks. Alternative dosing regimens of darbepoetin alpha 100 micrograms once weekly, 200 micrograms every 2 weeks and 300 mcg every 3 weeks have reported similar beneficial effects seen with epoetin alpha. Response of erythropoietin-stimulating agents is monitored by measuring HGB weekly until stabilization. During this time, the dose should be titrated to the lowest dose needed to avoid transfusion. A minimum of 2 weeks is required before an increase in RBCs is seen. A reduction in dose, that is 25% for epoetin alpha and 40% for darbepoetin alpha, is required if there is a greater than 1 gram per deciliter rise in the hemoglobin in any 2-week period, or the hemoglobin reaches a level to avoid transfusion. If no response, less than 1 gram per deciliter rise in hemoglobin and hemoglobin remains below 10 grams per deciliter, is seen in 4 weeks with epoetin alpha or 6 weeks with darbepoetin alpha, a dose increase should be considered. Common dose escalation schedules for epoetin alpha include escalating to 300 units per kilogram 3 times a week if initially treated with 150 units per kilogram 3 times a week, or 60,000 units once a week if initially on 40,000 units once a week. Dose escalation for darbepoetin would consist of an increase to 4.5 micrograms per kilogram once weekly if prior treatment was 2.25 micrograms per kilogram weekly. The need for iron supplementation should also be considered at this time. Response should again be assessed at week 8 or 9 and appropriate dose reductions made based on hemoglobin level or transfusion avoidance. If no hemoglobin response is noted after 8 or 9 weeks of treatment or transfusions are still required, the drug should be discontinued. So there you have it, our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 508.